You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to this midweek special episode where I chat with Dr. Jonathan Hoffman and Dr. Katia Moritz from the Neurobehavioral Institute in Florida. We discuss the analogy cracking the nut, who cracks the nut, i.e. the case, working with tough cases of OCD, getting treatment ready, what makes OCD harder for someone, frustration tolerance, comorbidities, getting families and loved ones involved in the treatment process, and much more. And these midweek special episodes, which go out at the end of the month on a Wednesday, are made possible by and in partnership with the Neurobehavioral Institute in Florida, or NBI for short. I will be interviewing different members of their clinical team on a range of topics. NBI specialise in treatment and programs for anxiety, OCD, comorbidities, and complex cases. They also offer an intensive outpatient program and a residential program called the NBI Ranch, a supportive living experience that complements intensive treatment for anxiety and obsessive-compulsive related disorders. To find out more about their intensive outpatient services or the NBI Ranch, as well as to read some of their free information online about OCD via their blog, visit nbiwestern.com. So thank you to Katia and John for their time. I deeply appreciate it, and especially talking about these cases, people that experience OCD that find it quite hard to engage in treatment and make the progress. So hopefully this episode helps you if you can relate to that. And of course, thank you to you guys for listening as always. I deeply appreciate it. And without further ado, here is John and Katia. Welcome back to the show, Katia and John.
Thank you.
Thank you
for having us again.
Yeah, it's good to have you guys back. So we're talking about cracking a nut, or cracking the nut, I should say. So I guess firstly, describing what this phrase is about, maybe where it came from, and anything you want to say to set it up.
I think we had Kyle on the last show, and that was a Kyle statement one day, right? That he actually shared with us on the show that I need to crack the nut, and I think it stuck with us because it actually reflected a lot of it exemplifies a lot of like the struggles that people have to get to that moment where they're going to implement the treatment, they're going to go for the hardest things. So we've always been using it since, and so here's an honor to him.
Yeah, absolutely. And I'll link to that episode so people can check that out.
But even before that, I think this is always kind of a concept in working in mental health that maybe you don't have to call it crack the nut, because that could have, it's good that Kyle said it because it could have another connotation that's unfortunate, but you could think of it as a shell or an egg or the boundaries or defense mechanisms or indeed any layer that's preventing somebody from making a change. And it's interesting that when we say crack the nut, we didn't say who's cracking it. Is it the therapist? I mean, sometimes you could think of kind of a little creature or someone in an eggshell, they kind of could crack their way out. And sometimes a pressure has to be applied, or almost like a baby being born. There's many ways to accomplish the same goal. And I think that looking at it from all those different perspectives, because sometimes it's only going to be external. Sometimes it's going to be an internal push to kind of, another way to say it is crack the case, or just look at the structure or see where the structure is at its weakest point. Not where the person's at its weakest point, but the things that are preventing them from having their life is at its weakest point, to look at it from all of those perspectives so that we can actually all collaborate in what's the best way to actually identify what is actually preventing you from making progress, literally what the barrier is here we're calling it a kind of a shell of a nut, and get to what's inside and help that, as a first phase, crack the nut, but then actually help whatever's inside go out into the world in the best way possible. And I think that's kind of the broader conception of what this is.
Yeah, really good points. And I think, correct me if I'm wrong here, but NBI might see more cases that are harder to treat than, say, a general OCD clinic. That's not, because maybe people have sought you out because they've tried other rounds of CBT and ERP.
I think that is really, and more than ever, that is increasingly what we do, deal with these very, very complex situations where it's very hard to figure out what's going to make the biggest difference in cracking the case, finding out what's going to be the leverage or the solution or the insight a person's going to have. Or as Katia said, that aha moment when they didn't want to do it, but now they do want to do it, and there's like a quote that says, it's a tension between kind of staying, from a poet, staying in the bud is actually more painful than breaking free of it. And it's that moment that we want to create, that's a much more poetic way of saying it than cracking the nut, but it's really about blossoming. It's about that balance. What are you getting from staying in the shell or fighting coming out versus what you can get from being out in the world, from coming out, so to speak?
So, I mean, the idea of cracking the nut is really more about like taking the hardest thing that you have to do in terms of your treatment, the moment where you have to take all the skills you've learned, put it all together, and then break free to the hardest, like go towards your hardest exposure or your hardest, your biggest fear, and so if it is, contamination, you would take the most contaminating situation and really have to just stay with it and, work through the feelings. And I think that that's really kind of where we were thinking that there's a moment in treatment, there's a moment that we prepare for. And so the more severe, complex a case is, the more preparation it needs, right? So that's why it takes time. It takes hours and hours and hours. It's almost preparing someone for the Olympics. They're going to go through something so difficult. They're going to have to face such a adversity against OCD in many ways. OCD is the adversity at that moment. And they have to really be so prepared that our job is really to prepare them. Sometimes I say to people, sometimes that happens a few months after treatment. Like they have all the tools, the armamentarium that they need, everything they need, the skills are there, and they're still struggling. And then life happens. And then all of a sudden they're like, wow, I really need to do this. And then everything comes together in that push. And I think to me, that's what, breaking the nut means, is that, you're there, you have the skills, you're trying, but you haven't really broken free or really addressed your hardest things. And what we see with OCD patients is that they may address a bunch of things, but there's a lingering, really hard one, something that they've been avoiding. They work around that a lot, and that's always there. And I always believe that. And in OCD, it's like you have to make the soil not OCD growable, like you can't have a possibility of growing OCD in your soil. It has to like pull all the weeds out and keep it clean so you could see when it's popping up, because otherwise it pops up everywhere, right? So I think that creating that environment is what allows someone to be ready and to actually maintain treatment. Because I think, cracking the nut is not only about that moment, but also what happens next, right? Well, how do you go about, because you're going to be working on this for forever, right? For now, there's no cure for OCD. So people are going to be like addressing it and practicing and working on themselves. Even the best clinicians that have OCD will tell you that their OCD comes back with a vengeance at times, and they were working through it. And, it doesn't make them not have OCD, but that, using those skills and really being aware of how it plays a role in your treatment and, relapse prevention is so crucial.
And I think it's very interesting to think of kind of with OCD treatment, there's also a lot of paradoxes always and dualities, because in a way, the more, state of the art kinds of OCD treatments are ones of internal acceptance, but external fighting. It's almost like being a peaceful warrior, that you accept what's inside you. So I think there's kind of an interesting boxing analogy here. I think when we're in treatment, no matter how naturalistic it gets, you're actually sparring. But when you're outside treatment and you're in real life, well, that's the fight. So a person really has to do almost like what a boxer does, stay very calm inside, very focused on your game plan. And yet you're meeting an opponent who's trying to pick you apart all the time, which I think is a very, apt analogy for OCD. And it's really teaching people that if they don't do the hard stuff in treatment, if they will not be prepared to do it in life, just like somebody who's never actually done something difficult in a gym. If you're learning how to be a boxer or actually had a challenge, all of a sudden you're facing an opponent that you have no wherewithal to do the very complex things that somebody with OCD has to do, which again is this kind of inner peace and outer battle. And I think that's kind of what we're trying to inculcate in the people that we work with. And to come to that moment where they realize that they're in two fights. They're in an internal one, which is a fight in a very opposite direction because it's a peace, which is kind of a fight for peace, and kind of, I guess, a passive resistance, or however you want to call it, radical acceptance. Yeah. It's very, very Gandhi-esque, I guess, or Martin Luther King to actually do that. But in actuality, it is a fight. It's just your strategy internally and your strategy externally are radically different.
Yeah, really good points all round. And I think the you said there about having a strategy or a game plan and not getting, well, frazzled is my word, but frazzled when it's game time, and then you sort of throw the strategy out the window. And it reminded me of, I don't really sail, but sailing, if suddenly there's a big storm, hopefully the sailors don't panic. I'm sure they're scared, but they know what to do. They know what ropes to pull. They know what protocols to follow, and they don't get thrown off by the 20-foot waves or whatever it is. Doesn't mean they're not terrified, but they're sticking to their plan. And I think, same with OCD. So sticking with the whole nut metaphor analogy, I get the two mixed up. If we think about like pistachio nuts, which are my favorite, they're already kind of half open, right? Ready to be cracked and eaten. And then you got the walnut, which is very hard and completely closed off. And not to compare people to different types of nut, but I think maybe there's something in that about some people come to treatment for whatever reason, and they're already they just need a little bit of cracking, so to speak, to get to the center. Whereas maybe some people a bit more closed off, not because they want to be, but because of life circumstances, or it's gone on for too long, or whatever else, familial stuff, or
I love that. And maybe that could replace DSM, that we just categorize like sort. But actually the psychological construct that goes with that is readiness for change. People come to us at all different levels of readiness for change. I guess the hardest nut to crack, so to speak, would be pre-contemplation. That a person, and this happens, people come to us and they might show up for various reasons, but they're kind of in denial. They're unwilling to change. They don't even have an idea about it. And we're kind of the enemy. They're more, OCD isn't, or anxiety isn't the enemy. It's us. It's the treatment. It's their families. It's everything like that. And then the next stage is you're thinking about it as contemplation. That, all right, I get it. I'm not doing anything, but I kind of get what you're saying. And some people come to us where, they can acknowledge things, but they're not really ready to do anything. And then it's preparation. Like, all right, now I understand. I'm ready to get the skills, and I'm ready to kind of move on a little bit, or at least have a plan. Like next week I'll do this, because our patients often say to us, all right, not today, tomorrow. Next week. I'll get this done by whatever auspicious date or whatever the portents say. And the stage we're looking for in treatment, of course, is action stage. And one of the interesting things is that you have to always apply the right kind of strategy, or in this case, the right, know what the type of nut is, and then what is required according to readiness for change. Because we know that if someone comes and let's say their family thinks is in the action stage, but they're in the pre-contemplation stage, we have a huge discrepancy there to actually deal with. So that's one of the things we really pay attention to, because again, if the approach doesn't match the readiness for change, then we're not going to be successful. So often on early in treatment, we're not really trying, we're just trying to get ready. As Katia said, we just kind of get ready for you to get the tools that you need toward that moment when you're going to make a radical change.
Stu, it's funny because I never thought of the person as a nut, which is very cute. I like that. I think that's a very good analogy too. But I think that on top of readiness for change, what John is very right about, is also there's so many variables about what makes OCD harder for someone. What makes someone a little bit more ready than others, right? And I think that they're important to really highlight, because for me, frustration tolerance, the ability to tolerate frustration, it's actually a superpower against OCD. And people don't really seem to talk a lot about that, which I find is weird. It's almost like speed for football. You can't be a slow football player. it's going to be hard. If you're very slow, like you need speed. And so I feel like people should practice, football players practice speed because it's so important. They practice strength because it's so important. Even outside of the game, that's what they practice, right? So OCD patients to me have a bunch of like skills that they have to practice in order to become ready for game day, right? They have to really be really good at tolerating frustration, distress tolerance. They have to be able to, know how to wait for the feelings, know that, it's okay to not feel uncomfortable. They have to thicken the skin a little, and you could thicken the skin by doing other things. You don't have to, it doesn't have to be only about OCD, because if you come to OCD treatment and you're used to having zero frustration tolerance, always playing video games and doing whatever you want, whenever you want, however you want, how are you going to fight this? That is not even a fair game. OCD fighting is for those who are ready to feel terribly frustrated, terribly uncomfortable, that have emotions and thoughts and, things, and letting go of that type of control. And if you, have all that all day control over your environment because you only do what you want, how are you going to fight, right? So to me, the hardest nuts to crack may not be the ones that are, not really realizing they need to fight this, but the ones that they are so weakened by their lives and the way they live every day that, going for this fight is even unfair. And I would say that that's why it's so important for us to work with parents. I mean, for me, if I don't have even the parents of adult patients involved in this, it becomes really difficult, right? I mean, different than you have a person who their parents are not in their lives, but if their parents are still supporting them and in their lives, like they have inadvertently provided an environment that make that person a great catch for OCD. And they have OCD, but they can't fight it out because they just don't have the strength, because everything for them is provided or accommodated, or anytime they are comfortable, the family's uncomfortable, so they fix it. How this person going to move forward on feeling uncomfortable if they've never even experienced what it is to feel bad, to feel good later? Did they need those, the blessing of the skin knee? You need to know that your knee could look terrible, and one day you look back and like, oh my God, it's all gone. It got better, right? So I would say that to me, there's such a much bigger picture of the steps that we need to get to the cracking of the nut. There's so many like very specific skills necessary to be ready for that moment.
Yeah, and that's why I think that, really thorough diagnostic assessment is very important. Time and time again, we find that, we don't do neuropsych testing routinely. It's expensive, it's time consuming. I mean, we as a field, but we as a clinic really advocate for that, because we could make assumptions about someone, well, they don't have good frustration tolerance, or they're not really committed to therapy. When in fact, it's because they have an undiagnosed comorbidity. They have a learning, they lack a learning skill that is fundamental. And I think, just building on what Katia is saying, that I think that we really need kind of establishing skills. And I think that's such a great point, that it's readiness for change, but are you ready, willing, and able? I think all of those kinds of aspects are very, very important, because we have to look for all of them. And I think getting the right diagnosis, how many people do we meet who've never had a diagnosis that they have autism because they present in a certain way, or it's a certain form that they're very, it's either very mild, it's not apparent, they've learned to mask it, or ADHD is a very big one also, that we're expecting someone to attend, or they have a memory issue. How do you, therapy is a learning process. ERP in particular depends upon a lot of learning and a lot of, generalizing. But if you have a problem doing that just from a sheer, cognitive perspective, from a neuropsych perspective, we really need to know that, because I think that's a lot of reasons why treatments don't succeed, because we just go right away into a kind of saying, oh, you have OCD, so we should do exposures. But what kind of exposures? Are you ready? Do you have the skills? I mean, willing, but also, as Katia said, I really want to underscore that we have to determine able as well. And I think that's kind of a missing ingredient in often a lot of treatment protocols.
Yeah, really good points. And I definitely want to talk about comorbidities in a second. On like Sorry, Katia, I'm blanking on what you said. It wasn't distress tolerance, was it? What was the
frustration tolerance?
Frustration tolerance?
Yeah,
I guess we
frustration
could say
tolerance
distress tolerance.
Yeah, no, it's
Is
different
it
actually.
different? Okay.
Very different. Yeah, very
Okay.
different.
Yeah.
So that's a concept Albert Ellis talked a lot about. And actually a lot of the behavioral health issues for me are connected with low frustration tolerance. So it's the inability to tolerate frustration, which is very different than distress, right?
Okay.
So even like if I'm so used to going to a restaurant and because someone knows me, I sit right away. And if I don't like to go shopping because I don't like to stay on lines, and then I go online and buy everything, and I find ways never to have to wait, never to have to like feel uncomfortable that way, because it's not a distress situation. It's not I'm upset about like something stressful is happening. It's literally the everyday normal things that happen, right? So when you go to a doctor's appointment and you're waiting and waiting and waiting, some people just stay there and wait, and they're so chill inside. They're like, this is great. I have nothing to do here. I'm just going to relax. They don't have to get their phone entertainment. They just like kind of chill, right? And others are so upset. They go a million times. What? Why is this going on? Why do I have to wait? To me, in order to fight OCD, you need to learn to wait that feeling out. You need to be able to actually have some peace in the chaos of like having to tolerate something that is not exactly what you want. It's not distress, but it's not comfortable. And sometimes when people are working on their OCD, it's not super stressful. That, of course, sometimes is terribly stressful, but OCD is every second of the day is that filter, right? So in order to work on that everyday thing, you have to be able to feel really tolerant to frustration. You're like, oh, this doesn't feel right. It's the yucky feeling inside when you're not getting what you want. And OCD is such a master of that, right? So when I think OCD as a condition, it's so brilliant at getting people to work for them for OCD, right? Because it gives you that unsettling feeling that it may not be so terrible, but will be so good to get rid of. So it wouldn't be good for the doctor to call you in. It wouldn't be good for the table to be yours. It wouldn't be good for you to buy the thing you wanted, you didn't want to wait for. All those reliefs that they build up on us, they're building blocks. So I find that the people, and I think that that's really important for us at our clinic, the people that we teach to learn to have no problem waiting. I think that success comes from waiting, right? So I think that, if you go to college and graduate school, you need to have very good frustration tolerance to get there. I don't think that's any different in OCD treatment. If you don't have that, I can't imagine how you're going to have the tolerance to go through everything that is going to happen in order to get to getting better.
Yeah, I think another aspect of this is that we use words like frustration without really communicating to people what they mean. And one of the things we really try very hard to do is give people what psychologists call operational definitions, a definition that is so specific about a word like, a general word like frustration, which people just use very colloquially, but use it very, very specifically. Technically speaking, at least to my way of thinking, frustration means you're blocked in a goal. So in that technical definition, it actually provides the solution. You have to change your goal. Like, for example, if you're frustrated because you can't get a relief because you're having an obsessional urge and you're frustrated, or just as Katya's saying, you're just sitting somewhere, you're blocking your goal of getting your needs met right away. If you change your goal to, I want to build a high capacity to have, to internalize your goals rather than externalize them, get what you want, but actually get what you need, which is to actually change your goal to, I'm working on a skill. And helping and communicate that effectively to people means being very, very specific and avoiding like terms which we assume everybody understands the same way, but terms like it's surprising how you ask many people, the most educated people, and coming up with an operational definition for anger or frustration or anxiety is very, very difficult. Now, maybe there are other definitions, but the ones that are most practical to use in the kind of treatment we do are these very, very specific definitions that a person can immediately spot, hey, I have a goal, I'm being blocked in it, but that's not really my goal. I'm working on something much bigger here. And that is actually a great process for cracking the nut too, because that helps build that skill, the readiness for change and an ability.
Yeah, really good points on that. And I think I don't know, something I've noticed a trend in maybe just in the UK, but I'm sure it's not. Like there seems to be a movement of so many people have ice baths now, like as in they buy those purpose-built ones or they're taking cold showers. There seems to be some kind of small societal, movement towards feeling discomfort and frustration. And maybe because I guess the other part, maybe I'm getting too philosophical or sociological, but like if we think about, regardless of what the media says, for most people, the world has never been better. It's never been more comfortable. You know, there's so much technology, and especially in the US and UK and other Western countries. And I guess our tolerance for dealing with frustration and discomfort must be at an all-time historical low compared to 400 years ago, you know?
Yeah. And, it's very interesting when, again, you put this in kind of a scientific term. In fact, the more comfortable you get, and it kind of reminds me that, that kind of saying that more problems come from success than failure. In a way, we're being like, we're kind of victims of our own success, because the more you can get something right, the more your sensitivity to a smaller thing being wrong occurs. It's just one of those things that happen, So your sense of just noticeable differences becomes more and more acute. If you're used to the finest of meal, let's say, then the slightest thing that's a little off, it's almost like, I always think of the analogy of the princess and the pig. You could say that's a sign of aristocratic blood or something like that, that the princess can tell under many mattresses that a pea is there. But I said, wow, that poor woman has really sensory issue here. To just imagine going through life noticing a pea is bothering you. But so many of the people we work with are princes or princess of the pea in many respects, and so are their families. It's not only the people that can't stand the frustration, it's also the families, which gets back to, what Katia was emphasizing was the point of how important it is to get everybody on the same page, that everybody is involved in learning the same skills, the same understandings, and we're all rowing in the same direction because we all have the same goal.
Yeah, good points. And I want to come to families in a bit because I think it's really important. So I want to spend more time on that. But with like comorbidities, are there common trends you see with certain comorbidities, or is it more case by case that kind of may make the case harder?
Well, it's always going to be case by case, because even within a comorbidity, people are different. But there are certain things that if you have, and let's just remind everybody that almost everyone who has OCD has one or more comorbidities. So it's always going to be an issue, of one sort or another. But if the comorbidity is autism, there are specific ways that you're going to do exposure that are going to be different. You're going to use more visual aids. You're going to present the information in a different way. You're going to use different sorts of language. Your expectations for change and the pace of treatment, and a whole variety of things are going to be different. If you have ADHD and you're not making progress, well, one, you need attention control training to actually help you get ready. Might you need a medication? Often that is the case. Will that medication make ADHD better, but OCD worse in some ways? So it should be in the hands of an expert prescriber. I know that's sometimes hard to find, but there are people who are really adept in balancing things that seem to be competing, like the impulsive part of the spectrum and the compulsive part of the spectrum. If it's more of personality traits, if it's more of a family, it's more of a family dynamic. If it's more depression, every single nut, so to speak, is going to not only be open for change in different ways, but actually is going to have a different process of opening it. Because, if you come on too strong, let's go back to a nut analogy, you might shatter it. If you don't apply enough, well, it just may stay unchanged. Or by accident, maybe you can make it close up. I don't know if you've ever had that experience with pistachio nuts, that you think you're opening it, and then you either, it gets broken or ruined, or you break the shell, something gets broken, or it's actually, you could find a pistachio nut, and there will be a certain number in every bunch that's actually completely closed.
Yeah.
And that's frustrating, right? What do we do with those? Well, sometimes there's a tendency to throw those away, right?
Yeah.
But of course, those are the people that we most need to pay attention to.
Mm-hmm. So just sticking with the nut. Sorry, Katia, if I keep those pistachios, will they eventually open for me? And I'm literally talking about the nut now, not as an
Well,
analogy.
I think that's the theory in pistachio nut management of families, that eventually will open up, but it's not a very good theory, because we could actually subject this, like in science. The nice thing is that we could always do an experiment. Let's say, and maybe I'll do this. Let's say we line all those pistachio nuts that don't open and come back in a week or a month. Would we expect them to open? Probably not. Maybe there could be
we'll have
some
to do
percentage.
something.
I don't know if they have spontaneous openness, or once they're plucked off the vine, so to speak. What happens, and that's the problem. And which one do you have? And that's kind of the process of assessment and the art of doing this, and understanding the real nuances that go into trying to have a successful outcome.
Yeah. I mean, you ask if there are common ones. I do experience as a practitioner and a supervisor and all of that, common conditions that we expect to see together. So, patients with OCD, you always look for ADHD, tics, and other movement issues. You look for a developmental delay from either an ASD, but even, OCD itself actually stops people from growing up, because you're so focused on OCD that you miss out on the growing up emotionally and personally, right? We also see a lot of, like, at least for me, a big component of depression. I mean, depression is a huge one in terms of treatment, and I find that really has to be addressed, because it becomes very discouraging in treatment. A lot of times have a seesaw effect where you're doing better with your OCD, and your depression then, becomes more of a problem, and vice versa. And sometimes they have a positive correlation where they go together, up and down. And so it makes it very difficult for people. I think that scares people a lot. Also bipolarity, when someone has bipolar disorder and OCD, an eating disorder and OCD, very, very common. So much so that at a clinic, we always thought that eating disorder, disordered eating and all of that was so important. But as our staff developed, we end up with 3 people that really treat eating disorders, and then 2 dietitians working with us, because there's always this component. And it was always interesting to me, because I always noticed that food gets into OCD, and OCD gets into food. They kind of have this weird relationship there. So I would say that those things are things that we see a lot common. But one thing that I find that it's a mystery and a very important thing to address is when people have all those very, very difficult physiological responses to a thought, and live this kind of battle life with OCD, how that eventually, and combined with other life factors, become more of a behavioral presentation that almost mirrors, or it may even evolve into a personality disorder, where people become super reactive, super dependent, have very nuanced things, which is hard, because we all question about the whole, and I don't want to get into this because John could spend an hour on this alone on if it is, or what it means to be personality disorder or not. But what we see is that a lot of the refractory cases present very, very much with aspects of personality disorder. And our hope is that that is an emerging issue that we can address in treatment. So treating interpersonal effectiveness, distress tolerance, all those things have become really very important pieces of the treatment of OCD. And that's why it's important that treatment has to evolve with a understanding, right? We can't write a protocol in 2000 and not really recognize that there are many aspects that we've learning over the years that needs to be addressed. So, emotional regulation is a huge one. Sometimes our problem with patients is not that they can't do their exposures and their work, but their emotion dysregulation is so severe that they put themselves at risk, right? And that if you have emotional regulation issues, distress tolerance issues, interpersonal effectiveness, it creates a very chaotic environment. And if you have many patients at the same time presenting that same way, the burden on the team, and we talk about how the sausage is made, the burden on the team, the burden on the staff is tremendous, and on the other patients, and the other members of the cohort as well. And many times we have that, and the families are in the same kind of game, and they are very reactive. We have issues with splitting between family, patients, and the team. And so we have to manage all those things, and we can't be mad at that. That's part of the condition, right? That's what is evolving. But I think that we need to talk about the complexities. That to me is a huge complexity when you have multiple diagnoses, and then you have a structure of a family that seems like, I call it a personality family, right? Like, so everything is so reactive and everything is so audited and checked in, and all of a sudden it's super overwhelming to treat. And then we get sidetracked, and the energy really has to be going towards OCD and OCD treatment, right? So I think that separating, like how people do, there's a program for OCD, there's a program for personality disorder, there's a program for trauma, there's a program. It's very hard because people are not pieces, right? They're one. And so I find it that learning how to do that together has been very important in complex cases. And to crack the nut, if you don't get to that understanding of this is something else, there's something else here that is stopping us, I don't think we get to crack that nut.
Yeah.
I think it was a word that was used, refractory. And that's a very interesting word, because we use that word to say someone has OCD and they didn't benefit from treatment. But is it that they didn't benefit from OCD treatment per se? Because that would be like saying I went and exercised and it didn't benefit me. I mean, that's very rare. I mean, if you do it, exercise tends to work. It would be like lifting weights, say, well, that doesn't affect my muscles. Actually, what a lot of people are refractory or deemed refractory, it's not the treatment for OCD per se. As I said, it generally works. It's especially exposure. I mean, it's just the nature of that kind of exercise to be effective. They're refractory actually to engaging in the treatment. And I think that differentiation is not made enough. And I think that's something that's very important to communicate, because people will say, nothing's worked for me. Well, that's like saying, well, I'm not getting in better shape. Have you gone to the gym? When you went to the gym, did you actually stay on your phone, or did you actually exercise? And I think those questions are really important to raise, because often the answer is no. You actually haven't done the treatment. It's just like when people say medications don't work. Well, did you stay on it? Did you use it as prescribed? And often the answer, really, when you look deeply into it, is no. So I think we need to really focus on that before we actually give up on so-called, that example of that great example of pistachio nut that isn't open. There's many, many reasons for that.
Yeah, it's a good point. Sticking with like the gym analogy, I go to the gym a couple of times a week, and I always see people and they're doing way lower weight than they should. Obviously, I don't know if they have a pre-existing injury or something, so maybe that's why, but it's way too common. I see people lifting way too low of a weight. And I'm thinking, you're not going to get muscular failure doing this. And that's where your arms or legs or chest, whatever it is going to grow. And I guess you could think about that from like a therapy point of view. It's like you could be doing ERP, but are you doing it the right dose, the right intensity? Are you hitting the right muscles?
I love that example, Stu. It's the right engagement. I know that sometimes in gyms, they actually have a scale, how much you feel engaged. And they actually should do that with students too, because you could say you're spending 2 hours studying, but how much time of that were you on task? How much time, even if you're on task, are you actually mentally processing the information and embedding it in long-term memory? So time spent is a very poor parameter. Or like time spent in the gym, as I said, you could be, what if you spent 50% of the time, talking to other people or being on your phone or answering your email, whatever it is. You actually you're going to the gym, true, technically. But are you really present? Are you really there? Are you really engaged? And that's a metric that we want to always be assessing with our patients. From lifting weights, you could always cheat on how you lift. You could actually, some people fake lifting higher weights. They're not really lifting them because they're not lifting them with the appropriate muscle. And they just they're more focused on the appearance of doing that. And we certainly see that with patients and families that it's for appearance sake. I'm doing it all, but are they really doing it? Are they really engaged? It's always a question that we have to continually be assessing.
Yeah, good. And with families, just anything you guys want to say on that, like getting the families involved and and that involvement being really productive for the sufferer.
Yeah. Well, I want to say everything about that, right?
Okay.
Not something, but I mean, to me, like the importance, I think when you talk about OCD, there are many variables that contribute to treatment. One is all the stuff that we've been talking about and the full understanding of the case, so you could dismantle all those little pieces and actually give skills so you can actually walk away from those diagnoses. And meaning, like, if you're developing a personality disorder and acting that way, how do you turn around and act differently? And all of those things are so crucial. Frustration tolerance and all that. But I find it that, like, over the years, when I have when we have families that really get it, like John and I are old now, right? I mean, John older than me, but like, let's not say that. But if we see our people, we get, one of the biggest joys, I probably say really biggest joys for me is getting emails. I just got one this week, and someone that I hadn't seen in a long time giving me an update on their son. And, we get like messages and everything. And that's really important. And I find that those success cases have a very strong correlation with the families that really kind of like drank the Kool-Aid a bit, like, and Kool-Aid is no longer a cool drink. So maybe I'm dating myself here, but like, it's really important to realize that, we are part of people's lives for a period of time, and even though we are maybe there a lot and, really interacting with them, it's a short period of time. We're not there for a long time. But their families are going to be there forever. Yeah, so I find that the families, more than even just engagement, because people think that they are really participating, but they are actually helping OCD and not helping their loved ones. And helping their loved ones sometimes takes courage and takes a little bit of a different approach to how they love. We always say, like, love is unconditional, but everything else is conditional. And you can't just keep giving and giving to make up for the suffering. So one thing that is very common is, all of us parents know, if your kid is suffering, oh my God, you're suffering so much. And we don't even see, even ourselves, we don't see that we're maybe covering up or enabling or giving more than we should. But by giving more and by covering up and by not doing the right things, we make this a much more difficult battle, because we don't prepare them for the life that they have to live and work on things that they need to work on to be successful and happy. And growing hurts. It's painful, even for people without OCD. So it becomes like a very complex issue with families. And so I feel like, really the outcome has a lot to do, and a very positive variable here is if we have families that are supportive and know what's going on.
And another dimension of that I think about is the continuum of being willing to learn. Are people willing learners? And in a way, your first family session and interaction can tell you that, because I'm certainly not saying people shouldn't question, but a lot of times they're just listening to hear what's wrong or why it won't work, or to say what happened before, what they think should be done. And it's a learning style. So families come to us with all sorts of learning styles. Now, their learning style might have helped them in a career. It might have hurt them. But it is their learning style. And I think we have to be very attentive to where that readiness and the skill that a family has in itself to be willing to actually learn from the people that you're asking help for. Sometimes I talk to physicians. Some of them are patients, have OCD as well, of course. And, one of the things that they, any physician knows is that when the patient comes in, is the first thing the doctor says, well, no, that's not the way it is, or that's not how it is for me. Their prognosis, assuming that the physician is giving good information, is actually going to be much poorer than somebody. It's not that we don't want to hear a difference of opinion, and we certainly want to be collaborative, but when it's so overdone, it actually becomes just another part of the shell. And parents don't realize that. Well, yes, there's the accommodation, the scaffolding, and all of that, but it's also the learning style of a family. It's also how they know how to argument or disagree, or how their own frustration tolerance, or how to be patient. Because anyone who's been a therapist doing this knows that you can see someone for a couple of sessions and people say, well, I don't see any changes. You know, but that would be an interesting thing going back to our gym analogy. That would be an interesting to say, I've gone to the gym 3 times. I seem to look the same. You know, it's just interesting how people, the expectation of change, the connection with what they're doing with change, really are all parts of this assessment process and what we have to deal with as well, and how much pushback there's going to be on that. And sometimes there's so much pushback that people say, well, then I'm leaving. If you're not going to do it the way I want, then you're not for me. You know, and it becomes just a distortion of what the process is. And without realizing that what they're just asking for is just more of the progression in most cases. Not that we're the be all and end all, they certainly go other places. But most of the time, they're just, you know, they're just finding a reason that doesn't actually make sense, a small detail that accounts for almost nothing, or like I didn't get a call return time, or you didn't, or this session was 2 minutes too soon. That becomes a kind of a way of supporting the shell rather than helping break the shell, and that's something very important to have frank discussions with people about. And is a really big part of our psychoeducational process.
The reality is, people are people, and they have upbringings and lives and emotional stuff. Like, you're talking people like as if OCD then is the only thing that they have and nothing else is counting, right? And that's why protocols are so difficult, because the reality is like, no, I mean, those are people with a history and a parent and a way that they lived in their house, and the way that, you know, we do a very intensive parent program, like a 3-day really deep dive, because a lot of times people don't realize how their own, you know, kind of like, you know, histories, because we're behaviorists, we can't talk about the past, right? But that's not true. Like, past behavior is the best predictor of future behavior. And, you know, a lot of times people realize that they grew up in a house that either was so invalidating or so too validating, and then they're doing the opposite, or they're repeating something that they didn't want to repeat. So actually being able to reflect on your parenting, I find that our OCD parents are the most well-trained parents, because they have to manage something that is so extraordinary, right? One thing is, you know, everyone understands that telling your kid, like not giving heroin to your kid, is something no one says it's okay to do. Everybody will frown upon that. But not giving your kid extra soap, it's just extra soap. Not washing your kids' clothing an extra few times, or not checking the door with them, or not taking them on the same route they wanted to go because they feel that there's something wrong there. Like that, like, you think it's a mean parent that doesn't do that. Who wouldn't do that for their kid, right? So being a parent of, you know, it takes a lot of like understanding and courage, because you're going to have to actually stand up to things that you thought you were supposed to be doing. You were supposed to reassure your kids. You're supposed to make them feel better. You kiss their boo-boos, right? So now you're saying, you know, don't kiss their boo-boos, don't make them feel better, you know, don't reassure them. Actually, sometimes say the opposite and make them feel worse. So that's a very, very difficult parenting strategy. And so for me, those are heroes, right? The parents that really understand how to manage OCD, and they become great partners to their children when they become older. So, you know, I've followed people that have been seeing, you know, and knowing them since they were little kids, and now they're grown adults with jobs and lives and, you know, relationships and everything. And it's kind of really cool to see that their parents are still actually their support system, and they go and speak to their parents, noticing stuff. And did you notice I'm a little more stressed here, or doing this too much? And that's a very nice thing to have as an adult, that kind of an adult relationship with your parents, right? Because I think that that's really what we're trying to do, is to make those relationships better, because OCD breaks relationships. It really damages them.
There's a food, I've actually never had it, although I am a little fascinated, called turducken. I think it's like a chicken inside a duck inside a turkey or something like that. Yeah. But I think, to stick with our analogy of cracking the nuts, sometimes we have nuts within nuts within nuts and so on. And that's, I guess, what we're talking about here, is the layer of shells. That it's a very interesting mutated nut. Like I'm sure someone in the lab could design like a nut within a nut or something like that if they put enough time within it. But I think OCD has become that way. And if we're going to kind of extend the analogy to a family structure, sometimes people don't realize they've adopted another child that has aspects that is OCD, has become a member of the family. And sometimes it's a very good idea to actually even chart that with people, to say that, hey, let's just externalize. We don't want to, in a way, we don't want to reify or make OCD like it's a real thing, because it's not like that. But in a way, it's very useful to do that to help people understand. So if they understand that, like in their family, if we're also seating OCD at the table, what are the characteristics of OCD? It's like someone has moved into your family and you've adopted it. And then all of a sudden you realize they're kind of sociopathic. Mm-hmm. I'm sure it's been the plot of a lot of movies, but that is actually what people are dealing with, and helping them come to that realization is a really important part of this whole process.
That's a really good point. So this like 3-day training you do, is that, I mean, how often do you do that? Is that like with every new patient's parent, or
and
optional?
This is a journey for everyone. And I think the idea of like, mandating people to have to do it in a certain way does not fit for them, right? Yeah. But I find it like, as a parent, and all of you here are parents also, we know how hard it's been to be a parent. I mean, that is really challenging. We could actually share stories about like all the moments and the difficulties, right? And I always wanted that for myself too. I really wanted to have someone helping me reflect on why was some things more difficult for me. Like if I and I really believe that as parents, look, if you are an executive, you spend hours and hours in executive training. If you're a clinician, you spend hours and hours and hours on clinical training. If you're a parent, you spend 0 hours on parenting, literally 0. Like if you think about it, you may read a book here and there, and there's not even good books right now, like, Forever. It's been not a really great book on this, but like, there's no really time to sit down. And I see it's a benefit. Like when we have the families come in, you learn so much about yourself. People go to like retreats all the time to meditate, to feel better. But boy, I mean, your parenting is one thing that affects your happiness tremendously. I think probably the most. Everything could be good. And if your kid and your situation is not good and you're not doing the right things, it really affects you. So I think I more and more I wanted to do that, Stu. Like more and more I wanted to figure out like a way to build those relationships. It's a funny thing. Like I'm talking to you from my mom's house in Rio de Janeiro, Brazil, and I think that is so important for anybody that if you have a family, your family continues to be your connection, and no matter how old you are, like no matter how much time has gone by, having those support systems when we can make a big difference in people's lives. And so I do believe that, parenting a kid or an adult, even more difficult sometimes with OCD, is probably one of the most interesting parenting challenges, because from the outside world, people don't understand. They think, oh, lucky you, your kid has OCD. At least they don't make a mess in their room like my kid does, And you're like, oh my God. But other parents will support you if you had a kid that has something else, or, and they understand it. They're like, your kid has another condition, and they're like, oh, wow. So I really find it fascinating, the journey for those parents, and how much they learn, and how much better their lives are when they understand their role in how to support OCD.
I know there are people out there listening saying, I wish I had a parent, or I wish I could access this, or, I don't have time. My parents didn't have time. They had to work 3 jobs or something like that. And I think we have to realize that paying attention to this it's being able to and have the wherewithal to pay attention to your parenting and get that is really not everyone has that. And we want to just also give the message that whatever your life circumstances, you can use some of these ideas. And even if it's not your literal family, and whatever your circumstances were, or your family didn't, some people have families that disengage them or hurt them, or they have traumatic backgrounds or things like that,
absolutely.
That they can figure out this is just kind of a way of looking at it, that we're being literal, that it's your literal parents or literal things. But there's a way of incorporating all of these strategies and all of these ideas into whatever your life situation is to translate it. And that's something that can be effective as well.
A lot of times your friends are the biggest enablers, like how many times we sit with people and realize that their best friend is the one that is providing all the reassurance and enabling because they don't understand what's happening. It's a spouse, it's a coworker. How many times a coworker is actually covering for your work and doing things for you because
and ultimately it's yourself. Sometimes sometimes people are so isolated with OCD that the relationship they can form is actually being good to themselves. When we talk about a self-compassion and things like that, that the actual primary relationship is that relationship. And there are ways to make it less toxic, make it more productive, make it more loving, make it a more caring relationship as well. Then that's when people start to actually take a step in actually cracking their own nuts in that way too. Because it's very easy to become bitter and feel like you're not cared about and be isolated and just lose all sense of what's OCD and just become like it's all enmeshed, which is a family therapy term as well. I don't want people to lose hope if they're hearing this and saying, well, how do I do any of that stuff? Look where I am. I'm just isolated. There's always a place to start.
Yeah. Oh, absolutely. Yeah. If you care about yourself, then there's always someone that cares about you,
Exactly.
Yeah. Self-compassion is so important. Hard for some people, but it can be worked on. So I guess, I just want to open up to you guys. If there's anything else you guys want to share on cracking the nut today.
I think for me is wherever you are, whatever your situation is, it's different for everyone. And we could say that, we all need to figure out a way together. And, I think that's why we come and speak to you, Stu, which is like giving a message to people like John is saying, you may have a parent, you may not have a parent, you may have children, you may have not children, you may have your cat, you have anything that is connecting you. And if you don't, it's time to go out there and try, because OCD is stopping you from having those connections, right? Yeah. So we want to have those connections, and those connections are part of cracking the nut, and also working on the skills. Like there are skills you could practice before you get to face the big fear, right? Because you're working on it as you go, get stronger, So for you, like when you go to the gym 2 days a week, when you have to do something physical, you feel like, well, I could go on that hike because the 2 days a week have like supported me on that. So what is the 2 days a week for other people? When you have OCD, there are exercises you need to be practicing skills. So then you can actually evolve and do the things you want to do in life. It will support you in those moments, right?
Yeah.
So for me, that's really the important thing. And and you crack the nut and the nut seems to come back, and then you crack the nut again, and that's how life is. There's no it's not a one and done, right? And so I think that's really part of the concept of moving forward and waiting. I always think it's so beautiful the moment where someone realizes like, okay, I'm gonna go for it. I'm gonna have the courage. And so I always say this, and I mean, I wish people courage. If I could wish something for OCD patients, it's just courage, meaning like, I'm going to do this, even though if it's uncomfortable, I'm going to take a chance and I'm just going to go for it. And so I think having that belief that I'm going to go for it is really the key ingredient here.
Yeah, true.
I'm just going to riff on the famous quote from Bruce Lee, like, be water, just in life, or not just in martial arts, but in life. Be what you have to be to adapt to your circumstances. So I'm just going to go up on a really deep philosophical thing now and say, yes, and technically speaking, I guess you're the nut or whatever's inside the nut. But I would also say the more you can be the nutcracker, the more you can take the position of the nutcracker in life in your own treatment, the better things are going to be, because people can try to support you and or stop you or do all of these different interventions. But ultimately, throughout your life, you're going to have to be the one who's accountable for cracking your own nut. So it's an interesting space when you embrace that space, that, again, another duality, to be both, that you're the pilot and the passenger on your same trip. and you make sure you go in where you want to go, and that's what I would just say, if it's not too, esoteric a statement, is to be the nutcracker. And that's how I think it's important to look at this.
Yeah, really good point. And you mentioned Bruce Lee there, and another quote comes to mind, which is, I can't remember what he said, but it's something like the man you should fear is the one that's not the man that's practiced 10,000 kicks once, but one kick 10,000
times. Yeah, and I also like, it's kind of a waste of time to prepare for an easy life. What you need to do is prepare for a difficult one. But we could there's so many Bruce Lee quotes that we could actually use, and for many people that actually are so instructive and inspiring for anyone dealing with this.
Yeah, I mean, he's a guy.
I like the way he says that's so true.
Yeah, he probably would have been good at dealing with discomfort and frustration. He strikes me as someone that could push through that. But yeah, I think I brought that quote up because quite often I see in the OCD community, and I was guilty of this in my early days of recovery, of looking for the next fix or the next cure and not giving the last one enough time to really take effect. Whereas, just take ERP, if we really give it a good go and work really hard at it, we're more likely to see it. I can't guarantee it, but we're more likely to see an output or a result than if we just try it once. Same as if we then move on to ACT and we just try that once. It's not going to be the same as if we really commit to it for a bit.
Yeah, and at the risk of too much Bruce Lee statements, my favorite scene in a Bruce Lee movie is where he practices radical acceptance in Enter the Dragon, where he's fighting, and all of a sudden he realizes he's trapped, and he just sits down in 1 second and just accepts it. So he is actually the epitome, and I think very purposefully, of the person who can both practice radical acceptance and radical external fighting. And that is actually in the essence, again, of what we're trying to do.
Nice. I like that. Well, look, thank you guys for another good episode. I love this one, and it's probably not talked about enough, these harder cases, and sometimes they get left by the wayside, which shouldn't happen. So hopefully this episode has helped a lot of people. I'm sure it has.
Thank you. Thank you again for having us.
Thank you for listening to this week's podcast. And thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us with a one-time tip/donation, please go to theocdstories.com/support. All tips, no matter how large or small, are greatly appreciated. Please subscribe and rate the show wherever you listen to the podcast. So thank you to NBI for supporting our work, and if you would like to find out more about their intensive outpatient services or the ranch, head to nbiwestern.com, or the link will be in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.